It's easy to tell when a man has erectile dysfunction. In women, the problem of sexual dysfunction is much more difficult to diagnose. As a matter of fact, unlike male sexual dysfunction, there are no criteria actually established to define it. So the problems that women have tend to be, like men, age-related, especially around menopause, but not all of them. Women of all ages, for example, may experience problems with orgasm. The good news is that, like men, female sexual dysfunction issues are largely treatable, but you have to look for help. And this week's episode of Sapio with Buck Joffrey is an attempt to provide information to women who might not otherwise seek help. I speak to Dr. Duncan Turner, an OBGYN in Santa Barbara who has 40 years of experience in women's health and is an expert of female sexual dysfunction. Now, I got to apologize in advance that it's two guys talking about women's issues, but I can't really control that.
In pursuit of health and wisdom, Sapio with Buck Joffrey.
Welcome to the show, Duncan.
Thank you very much. Pleasure to be here.
So let's start kind of with a question I think that maybe it's not related to sexual dysfunction, but out of curiosity, you've been working with women for years. You happen to be a man yourself. And would you say that, is it fact or fiction that men just want sex more than women?
I think it depends on the age of each of those sexes. Men, I think, want it earlier in their life, and then tails off probably with testosterone. Women seem to be more comfortable by and wanting it more later on, and maybe that's a benefit of the closeness of the relationship that they're enjoying at that time.
In teenage years, though, is it is it about the same, or boys, I know the boys part of it.
Right.
But women, girls just have a higher libido at that point too, or not so much?
No, I don't think so. I think their libido goes on increasing.
It increases over
Yeah.
time. Got it. And how long do you think that sort of with women stays constant at that level?
It's fairly constant up until menopause. From the
Got
time
it.
they start having periods or even knowing about sex, it's pretty constant up until menopause.
Before we start this conversation about all the different reasons and treatments potentially for sexual dysfunction, I think a good place to start is, well, let's define it. What exactly is sexual dysfunction in women?
Yeah, right. Easy to say in men. That's well documented. I think this is almost a personal matter for a woman. It's are they as interested in sex as they want to be? Or are more demands being made of them by their partner and they're just not feeling quite like that. So I don't think there's a right and a wrong or a somebody who's just not interested in sex or having is dysfunctional. I don't think that's the case. I think it's really a matter of individually what do they want.
Right.
And so it's hard to put a definition on it.
Yeah.
In fact, I thought about this and I really can't put a definition on it. But there are terms for it. There are terms in the ICD-10 codes of hypoactive sexual desire, and but it's so individually based. It's really what the patient wants.
In men, it's pretty well documented in terms of how common the problem is. Sounds like approximately maybe 52% of men over the age of 40 experience some level of dysfunction. I know you can't define it, but do you think the problem in women is as prevalent?
Yes, I think it is. I think it's as prevalent. It's just not talked about very much. Even women talk about lots of things together, but this is one that they don't talk a lot about, it seems.
What other medical conditions can, potentially affect a woman's libido? Maybe, is part of that workup. I'm just thinking about other things that could, somebody gets, some other health problem. I don't know if diabetes or, any type of other kind of chronic health issue affects.
Yeah, they're gradual changes, certainly. Diabetes is the one you mentioned, that certainly will make a difference. It's, as I say, it's almost always for those patients that it's very unusual for there to be um, a psychological change for a woman that suddenly occurs in their 30s that isn't explainable. So the numbers of patients with a hypofunction of their sex drive is cerebral. It's not that common.
Yeah. Sex around pregnancy and after
Hmm.
childbirth. How does
Yeah.
that change?
Uh, yes. Again, most of it's very um, well explained in terms of tiredness, but there's body image that comes into play at that point. Their role as a mother has changed. Their focus has changed. The way they look at themselves changes. Um, the and certainly hormonal changes what I was talking previously about the normal menstrual cycle, how that varies in terms of how that causes their libido to vary. With pregnancy, their estrogen levels are very low after delivery, and they also have uh, uh, a lower estrogen effect on the pelvic tissues, and so it's not only maybe some residual pain from childbirth, like lacerations, episiotomy, even C-sections. All of that can have an effect. The point really is that there's an explainable point for that. There's an
Yeah.
explainable reason. They have pain with intercourse because of the lack of
Yeah.
estrogen.
So would you say it's, what's the incidence or maybe not specific incidence, but is it a common problem to start experiencing some problems with libido and pain with sex, things like that after pregnancy then? Or,
Yeah, temporarily, particularly when women are lactating.
mhm.
Again, hormonal reasons most of the time, but a lot of that is, as I say, psychological. Their role in life has changed.
Just talk about estrogen because
Yeah,
it sounds like you
it's
mentioned that
all
this
about
is
estrogen.
it's all about estrogen. Yeah, that's my motto.
You know, absolutely. It was. I remember in the 60s and the 70s hearing the term estrogen as the fountain of youth, and it has fell out of favor, and we'll probably go into that later.
Yeah.
But that's close to the truth.
Okay. Well, let's talk about it because I don't know very much about
Okay.
estrogen. What's the importance of estrogen here? Or, maybe the wrong perspective on estrogen if we had one.
Well, the wrong perspective is for postmenopausal women was that it's dangerous to take and you're going to get cancer. There was so much damage done by the Women's Health Initiative study in 2002. And now we're beginning to get out of that because we have more studies that show that that group of patients for which the study was stopped were not people that would be started on estrogen these days because we know better than to do that. So estrogen itself has just got this bad name and it doesn't deserve it. For the patient that's had a hysterectomy, uh, will and is on estrogen replacement, she has a lower chance of blood clot or lower chance of breast cancer than if she took nothing.
Right.
Okay, so it is actually protective, and overall mortality decreases with estrogen alone. The study showed that if a woman was on estrogen and progesterone, if they started late, they were more likely to get breast cancer, but it didn't happen if they were started early enough. And now the general uh, recommendation of the North American Menopause Society, which is the body of knowledge that I listen to most, um, they are saying if you start early enough, which means in their description, by within 5 years of menopause starting, or before the age of 60, that it's perfectly safe to do it. And that comment was first made in, I think about 2015, 2017. And shortly afterwards, they added to that saying, you don't have to stop at 65, which was the thinking. You can keep on going as long as everything else is going okay. And so that's what happens. And now we have women who are on estrogen and progesterone, or estrogen alone for the rest of their life.
Okay, well, first of all, let's talk about what happens during menopause at the level of sexual changes, sexual dysfunction, desire, probably some anatomical changes that are coming into the. So let's talk about what happens there.
Yeah. So when estrogen levels drop, which happens when a woman would have a period, but in menopause it doesn't get going again. So you have the lower levels of estrogen, and the estrogen receptors that are all over the body, in the brain, and pretty much everywhere in the body, but absolutely focused in the pelvis. And the pelvis isn't just the vagina or the clitoris or the labia, it's actually the bladder and the bowel. And all of those areas need estrogen to keep going. And this is a huge change that happens to those tissues. The blood supplies go down, the collagen content of the tissue diminishes, and the tissues don't stretch. The nerve endings are closer to the surface, so they lose lubrication because the glands aren't working as well, the blood supply isn't as good. And so they lose lubrication for intercourse, and then with intercourse, because the nerve endings are closer to the mucosal surface, it hurts more. There's a greater sensation, but painful sensation. And then throw in some urinary symptoms at that time of urinary frequency, nocturia, having to get up at night to empty their bladder, or incontinence. And all of that changes because of the lack of estrogen. Now, estrogen isn't the only feature in this, but there is a condition called the genitourinary syndrome of menopause, which is a collection of symptoms that are vaginal dryness, pain with intercourse, urinary incontinence, urinary frequency, and those happen. That only got a name in 2014. Okay, just one of the other examples of so little attention being passed on to women's health. So that genitourinary syndrome of menopause affects 50% of women after menopause. And so they all are suffering from, in one way, shape, or form, from the lack of estrogen. Now, testosterone's dropped a little too, but that's not the major ingredient. The major ingredient is estrogen. It's not progesterone, it's not testosterone, not DHEA.
So you were talking about the changes in desire. I mean, I'm assuming like when you actually hit that menopausal period, there's a decrease in desire because you're saying that there are these issues that that cause pain. Is that the main reason?
Um, Ultimately, yes, but and I think initially the desire hasn't gone away, but patients will come in and say, "It's beginning to hurt. I'm feeling dry. What can I do about
Yeah.
this?" And that's actually a fairly easy thing to treat, and which is remarkable.
And is that just estrogen replacement?
Not only it's estrogen replacement has a big role in it, um, but other technologies that we have that basically are the same things that are used to resurface skin, tighten skin, put collagen in skin, blood supply to skin, like the facial treatments.
Yeah.
And the obvious example here is fractional CO2 laser, which is used for skin resurfacing for the face.
Right.
And some Italian physicians adapted that technology. You're smiling.
It's always the
It's
Italians,
the Italians, yeah. And they adapted that to be used intravaginally.
Okay.
And that became available in the States in end of 2015, 2016.
Uh-huh.
And I heard about it and I thought, nonsense.
Yeah.
Can't be true. But I've learned how wrong I was. And the and what convinced me, I had some colleagues that were using it, and But it was only just out. I'm a fairly early adopter of new
Sure.
technology, but I don't do this blindly.
Right.
And then I saw some histological studies, slides of pre and post treatment, which were just unbelievable of what difference it was making. So I looked at the machine, got trained on it, and got one. And then I thought, okay, well, what happens now? I'm going to have to find some patients. This is not something we talk about with patients. Even as a gynecologist, we don't normally ask patients how their orgasms are. It's just, or they don't usually come to us saying their orgasms aren't as strong as they used to be, or they've never had one and they want one now.
Sure.
So we thought, okay, we've got to get the word out on this. And so what do? We'll put something on the radio or on Facebook or something.
Yeah.
And we found we couldn't talk about vaginas or sex on Facebook at that time, and maybe still can't because they still block some words. Local radio here in Santa Barbara wouldn't let us talk about intercourse or sex or vaginas.
What year was
So
this?
this was 2016.
Oh, wow.
Okay.
Okay.
And
Yeah.
so what do we do? Okay. So I decided to change my intake paperwork for patients to ask, do you have any pain with intercourse? And do you have pain with intercourse? Do you have urinary incontinence? Urinary incontinence one was not one that was, patients usually tell you if that's an issue. But it was amazing how many people were answering this. And so in my paperwork that I was sending to the patient, they would check a box if they had, which was much easier for them to bring it up to me or me to them.
Sure.
But it started the conversation. I said, "Oh, you check this. Tell me about that."
Mm-hmm.
And that's when my life changed, really did, because suddenly there were all of these patients that hadn't had intercourse for like 10 years
Oh,
because
wow.
it was too painful. And we were able to treat most of those patients very successfully with a combination of a vaginal topical estrogen and the laser. The Mona Lisa touch was what it was called.
What is it called? The Mona Lisa?
Mona Lisa touch.
The Mona Lisa touch.
Yeah.
Well, it's Italian, right?
Yeah,
So,
exactly. It will have to be.
yeah. Is that so? That's the name of the.
That's the name of the first one that came along. And then, of
Okay.
course, with all of those laser type instruments, as you know, there's everybody's leapfrogging.
Then you get better ones and better ones.
But even though I have newer and better ones in my office now, I still use that original one because I know that it works, and it's more economical for patients
Yeah.
to use that one. And it's been and with these treatments, so we can resolve the issue. But then the patients need a maintenance. They have 3 treatments a month apart to start with,
Mhm.
and they can usually start everything working again. And then about once a year, they'll need a single treatment to keep it going. First of all, they need to keep the intercourse going,
Right.
and they need to continue to use the vaginal estrogen, they also need a repeat of the treatment. But it's changed things in my practice
What
significantly.
kind of would you say that it tends to work for most people with most women with this problem?
Yes.
Yeah.
Mhm.
And are these primarily, I mean, is pretty much everybody in that same postmenopausal state?
Anybody over 50.
Anybody over 50.
Yeah.
So it's not necessarily just postmenopausal. It's, women who are starting to notice any kind of changes. I mean, by 50, generally they're menopause
Yeah,
for the most part, but
yeah, average age of menopause is 52.
yeah,
So it's estrogen related. So they could be perimenopausal because
sure.
having said the average age of menopause is 52, for most women, they will begin to have symptoms of low estrogen from 5 years before that time.
Yeah.
So it's not unusual for us to have patients in their 40s with this problem.
I'm going to talk about, I'm going to back up a little bit. The one thing that we didn't really talk about is the role of birth control pills. Do birth control pills, do they affect libido
Yes, negatively.
negatively?
Right.
across the board generally?
Mm, do you mean by most patients that are on
Yeah.
it? Certainly a big chunk of those patients, a significant percentage. I wouldn't necessarily say it's not 100% by any means, but it's probably around 50%.
50%.
We'll have a change.
We'll have a change.
Yeah,
Okay. So it's not necessarily dramatic enough
to do anything
to
about it.
do anything about, but what can you do about it if there is a substantial decrease and you want
It
to be on
depends a
orphan?
little bit on what other symptoms they have.
Hmm.
So the reason for them having that change is because the estrogen that's given in the estrogen progesterone that's given in the birth control pill will suppress the pituitary gland so that the ovaries just kind of rest for a while. So and their estrogen level is fairly low throughout their cycle because they're not going through this ovulatory peak
Yes.
that we were talking about before. And I think that peak is crucial to everything feeling good. So the lower estrogen in the birth control pill can cause vaginal dryness, can make the patient less resistant to infections and bladder infections. Um, and those are reasons also for them not wanting as much sex. And the general estrogen level is lower. As I say, they're missing that mid-cycle peak, which is when women are
Mm.
where the libido is highest.
Are there different kinds of oral contraception that affect women differently in terms of sexual dysfunction?
Um, uh,
In other words, what I mean by
yeah.
that is, I know there are a few different types.
Mhm.
Are there some types that tend to cause less sexual side effects?
Uh, One of the things that's been done is to reduce the level of estrogen in those birth control pills so that patients had less breakthrough bleeding, less spotting, which was a nuisance. But it actually does the reverse. It doesn't help the the libido. In If they're on one of the older, more estrogenic pills, that problem can be resolved.
Got it. So is that typically what you will do in a situation where you've got somebody who's got that complaint, is put them on maybe some of the older.
Yeah,
Yeah,
yeah.
interesting. So I want to make sure that we cover a concept of orgasm. First of all, I
Right.
guess the first question is simple: are some women just wired to have less orgasms than others?
Yes.
Yes. And so if that's the case, is the women who would like to have orgasms more frequently or easier, is there anything they can do about it?
Yes, there is. It might be changing the estrogen level if that's a question. So there are blood tests that we would do to
And
see what.
this, just to be clear, you're talking about only postmenopausal women.
No, no,
No,
could
for
be
anybody.
any of them.
Okay,
We would
go
want
ahead.
to check the blood levels and see
Yeah.
where they were because sometimes it can be a premature menopause that is missed, and those patients are at way more risk long term. But other things that could be done if they are menstruating regularly for the premenopausal or they're on regular HRT
Yeah.
replacement therapy, we check to see what their levels are to see where they're going. So using oxytocin can enhance orgasm.
How common do you prescribe that? I'm curious because I actually have never heard of that, as a treatment. And is that something that most OBGYNs will know about and
No.
they don't? Just to be clear, you're saying that there is a potential treatment for the inability to have an orgasm in a woman, regardless of whether they're postmenopausal, premenopausal,
Right.
and it might involve oxytocin. What is
Oxytocin.
oxytocin?
Oxytocin is a hormone, and it's best known for stimulating labor, and that's what the trade name would be pitocin.
Right.
But oxytocin has been studied extensively. It's very safe to replace or to boost in somebody who's not pregnant, of course. That wouldn't work. Um, and that can be taken orally, or it can be applied topically to a patient to stimulate orgasm to make it easier and more intense. Now, testosterone can be used for the same purpose, or you can use them together. I think that it's just it's underused. It's very safe, um, but I've only recently been using it in the last few years.
How effective has that been?
Um, Significant. Let's say that certainly had failures with it.
Right.
Um, I mean, I have one patient I sort of try everything on that I can get my hands on because she's never had an orgasm in her life, and we're trying to solve that problem for her. Um, Other things that can help, as we talked about the Mona Lisa. Well, strangely, what we found also with the getting rid of the pain of intercourse with the Mona Lisa touch, the laser, um, we found patients were saying sex feels better. It's I'm more sensitive. I'm more lubricated. Um, my husband thinks he's a better lover suddenly.
Yeah. Right. There you go.
um, and it's and now with the advances in that technology, we found even more benefits to laser treatments and radio frequency microneedling too.
Radio frequency microneedling.
Yeah.
Okay, and similarly, how is that done? I mean, again, that is something,
So you're going down the right track here
right,
because it's pretty remarkable.
right. I mean, I think of microneedling in the context of cosmetics,
Yeah,
cosmetic surgery, and
absolutely.
that kind of thing,
Yeah,
where you kind of can apply it, but there must be some instruments that you can.
absolutely.
Yeah.
There are.
Okay.
So
Interesting.
they've been designed for
Mhm.
this. They're FDA approved for this in most circumstances. Certainly all the stuff we use. And they're just adjusted power wise and physically to be able to be used in the vagina or on the labia or around the clitoris.
Yeah. So, in men, it seems that I did a show again with Justin Howman, a urologist, on male sexual dysfunction, and the conclusion I came away with that was that really it seemed to me that the majority of cases of male sexual dysfunction, erectile dysfunction, you could address to a satisfactory level.
Yeah.
Do you think that that's true for women as well in terms of libido and anorgasmia?
Yes, I do.
You do.
Yes.
That's great. And then what is the role of, say, some of these other medications you hear about, the equivalents for women of the Viagra's and Cialis. I think there's something called Addy
Addie,
and something with a V. What?
Vilesi.
Yeah.
Yeah.
Talk a little bit about Addy and Valesi.
Um, they're non-hormonal treatments. Well,
Uh-huh.
actually, Addie is, I think, a SERM, a selective estrogen receptor modulator. Um, Problem with Addie is it's incompatible with alcohol.
Oh,
Thought
okay.
that's never going to fly,
Yeah,
you
yeah,
know.
yeah.
Vilesi is an injection that's almost like an injection-free D. So I don't have much experience with
So
either of
when you
those because I haven't. I felt I had better things.
So Valesi, you said Addy, of course, the issue there is a pill, and you said you can't have alcohol with it.
Right.
Valesi is an injection that is it like a once a week injection type
No,
thing?
well, I think they suggested that it was once a week, but um, I it was either with one that was taken 30 minutes before planned intercourse, or
Okay,
it might just be before planned intercourse.
right. Which makes it
Yeah, a little inconvenient.
yeah, a little inconvenient. It's
Right.
not like popping a Viagra or whatever you're
Right.
gonna do before, and
Yeah,
makes it a little bit
exactly.
easier. Um, I don't know how much your experience. You say you don't have much with them, but are those intended also to help with orgasm or just with libido?
I just with libido. I think that's where they're working.
So bottom line is it's hormones and technology,
Yes, right.
right? Right. One last question about the hormones though. Talk a little bit about testosterone. I don't know if we've hit it hard enough because it's a
No,
major role here
right,
when we're talking about
right.
sexual dysfunction and libido.
Well, it's a major role for actually both sexes. As testosterone levels drop from about age 18, 25, something like that for men. Um, all the way down, they're very low. They're in the 150, 200, 250. Um, and so that's part of the ED issue, and it's certainly part of the libido issue. So that if you were dealing with ED, you'd get those levels optimal. That would be ideal.
Right.
For women, it's really interesting because it's there's a company that started making testosterone pellets that could be placed under the skin in a minor procedure for men and for women. And it's one fairly frequently used way of men getting testosterone other than direct injections or creams. For women, as I said earlier, the variation in testosterone levels for women from the time they start having periods until the time they die doesn't change a whole lot. It's a little bit less postmenopausal. So to have an effect on women's testosterone levels or libido via testosterone levels, we actually have to go up to 2 or 3 times the level that they've ever been at before. So I don't look at it as a hormone replacement as I do with estrogen and progesterone,
Right.
but it's a supplement. And this was really developed by a company, BioT, that trained physicians and allied health professionals, if you like, how to put pellets in, gave them directions how to orchestrate them, and they set parameters, and they set recommendations of the dose that you use or the frequency you use and the blood levels you're trying to go to, and they've been extremely successful.
Right.
I have a lot of patients who have pellet placement for their hormone replacement therapy. I have a few that are just using testosterone that way, but we're getting to levels of 100 as opposed to 25.
Yeah.
Now, hundreds, we feel very comfortable about it as in terms of risk because men are walking around with 250 to 1250.
Right.
But it's not dangerous for women to do that, but that's really how it became popular. Great business model from the company. They did a really good job.
Yeah.
And I didn't do a lot of pellet replacement even for estrogen and progesterone. Well, we don't use it for progesterone because I didn't think patients would like it. And then I just had more and more patients asking for it, or that were moving to town and were getting it elsewhere. And so I started doing it. And I've got a big percentage of my HRT patients
Yeah.
who are doing hormones,
The,
doing
the
pellets.
pellets. Yeah.
Yeah.
So is if you're getting to those levels that are like 3 times as high as normal physiologic levels in women, are
Yeah.
you getting some of the testosterone side effects like
And
facial hair growth,
and
things like that?
yes,
Yeah.
occasionally, not a lot,
Right.
but acne,
Yeah.
odor,
Yeah.
um, and hair loss and hair growth.
Yeah. So that's not common though.
It's not common.
Not common.
No.
And then maybe you just back off a little bit and try
Yeah.
that. Yeah. Great. Well, before we go, I want to ask you about your podcast because you have a podcast as well, and
I
it's
do.
rather provocative in name,
Yes. The Vagina Doctor podcast.
the Vagina Doctor podcast. And what is that all about?
Oh gosh. It's actually it's about starting talking about this. It's about people being able to say the word vagina rather than some euphemism for it.
Right.
But we do way more than sexual health.
Right.
We're looking at, have a number of people that are coming to talking about anti-aging, and you're invited, as you
Yeah.
know, because we want to talk to you about that. Um, the We talk about the silliness of medicine, which there's some ridiculous things that we do in medicine,
Sure.
and the way it's organized. And basically, we're talking about people that are just of interest. So we have one of the first ones we had was a sex therapist who talked about what they do for patients. So
Hmm.
if we add this on to our conversation now, where do we go when I don't have anything more to offer? Sex therapist.
Okay.
So
I may need to get the name for another show there.
yeah,
That
yeah,
sounds
she's great,
interesting.
and she's
Yeah.
local too.
Yeah.
Um, And we also talked about, on one occasion, I had Julie Taguchi, who's an oncologist, talk about breast cancer and hormone replacement therapy because that's a big concern.
Sure.
Um, and yeah, it just has really been fun. I was Karen, my partner in both work and play, is she really wanted me to do this, and I was sort of dragging my feet a bit.
Yeah.
And then I agreed with her that it was something we should do because we wanted to get this word out. And I found it entertaining,
Yeah.
funny, and it's enjoyable. And I wouldn't be sitting
Yeah.
here without that,
Yeah.
probably.
Yeah.
So,
Well, I tend to agree with you. This is my second podcast, so
yeah,
maybe I'll find
right.
another one
Yeah.
after after you get this one going. Well,
Right.
it has been wonderful having you on, and
My pleasure. Thank you.
thank you so much for sharing all of your years of wisdom.
Thanks.